The importance of that is because the left side of the heart cannot function unless the right side of the heart is doing its job. So you have to evaluate the right side of the heart. And we looked at how to evaluate the function, the RV function, and we spoke about different methods that we can use to evaluate the RV function. We talk about TAPSE, tricuspid annular plane excursion. We went over the definition for that. We also look at RVS prime. That's another method, and we look at fractional area change. If you pick up, if you pick up that, say you're using TAPSE and your TAPSE is abnormal, then you have to use another method of assessment of RV systolic function in order to confirm that the RV systolic function is abnormal. So you can't just give me a TAPSE of 14 and then walk away. If the TAPSE is 14, then you have to give me another method, and the other method would be RVS prime. Okay, the other method should be RVS prime. And another thing again, guys, if you haven't, even if you don't have an abnormal, say TAPSE, look and make sure that what you're doing is correct. Because I've seen a lot of so-called TAPSE measuring, when you look at the cursor, it's through the right atrium. Okay, so pay attention and take pride in the studies that you're doing. You know, your assessment can can affect these patients, because if you give a faulty assessment, I mean, you know, you can either not make the correct diagnosis, or you can give them some sort of excess. So looking at the RV systolic function is very important. And then we look at how to assess chamber size, because when the RV, or the right side of the heart, is not functioning properly, the size will be affected and the function will be affected. So function and size is very important. And we look at hemodynamics, because hemodynamics is also very, very important. We can measure right ventricular systolic pressure, and hence pulmonary artery systolic pressure if there is no obstruction across the right ventricular flow tract, or the pulmonary valve. We showed you how to measure the RV systolic pressure. You have to have tricuspid regurgitation, and you measure the peak velocity of the TR envelope, and you use your modified Bernoulli equation to get the gradient. Gradient is 4v squared, so you get your peak velocity, you square it, multiply by 4, and then you look at your IVC, and your IVC will tell you what the right atrial pressure is. So we talk about a normal right atrial pressure is between 0 and 5. If we're going to give one number, if it's normal, then we usually use 3 millimeters mercury. That's right atrial pressure. If the right atrial pressure is elevated, very elevated, then when you look at your IVC, and we'll measure it, if the IVC measurement is greater than 2.1 centimeters, then you will, one second. If it's greater than 2.1 centimeters, and you have less than 50% collapse with your sniff or inspiration, then that usually suggests an elevated right atrial pressure of the order about 15 millimeters mercury. And in the subcostal view, this is how you measure the width of the IVC. Okay, it should be measured in end expiration, okay, just proximal to the hepatic vein, so like that. And we say the IVC is dilated if it measures greater than 2.1 centimeters. So greater than 2.1 centimeters, less than 50% inspiratory collapse, or with the sniff, then the right atrial pressure is about 15 millimeters mercury, or more than 15 millimeters mercury. So anything that falls in between is about 8 millimeters mercury, and this is a table that you need to know. Okay, so for an elevated right atrial pressure, the IVC is usually greater than 2.1 centimeters. You get less than 50% collapse with inspiration or the sniff. And when you look at your tricuspid inflow, you get a restrictive filling pattern, and the EE prime is usually greater than 6, and you get a diastolic predominance in the hepatic vein flow. For a normal right atrial pressure, the IVC is usually less than or equal to 2.1 centimeters, and you'll get more than 50% inspiratory collapse or collapse with with sniff. Okay, so you need to know the two extremes: what's normal, what's high. Anything that falls in between is intermediate, and we usually give the right atrial pressure 8 millimeters mercury. So that is if your IVC is greater than 2.1, but you get more than 50% collapse with inspiration, it's 8. If it's less than 2.1, but you get less than 50% in inspiratory collapse, it's about 8. Okay, you have to know this table. Okay, so those of you who are doing an exam, you definitely have to know the table. Well, even if you're scanning, you have to know the table as well. So again, in order to get your right ventricular systolic pressure and hence your pulmonary artery systolic pressure, you need to get TR, and you get your peak TR velocity. You square it, multiply it by 4, okay? And you had your right atrial pressure. If you want to develop the concept, then the gradient across the tricuspid valve in systole, that's the pressure difference, is equal to the right ventricular systolic pressure minus the right atrial systolic pressure. That's the gradient, the pressure difference. If you rearrange the equation to get your right ventricular systolic pressure, then the right ventricular systolic pressure is equal to the gradient plus the right atrial systolic pressure. So we just went over how to calculate the right atrial systolic pressure. If it's normal, and we went over what makes it normal. If you have the IVC measurement is less than 2.1 and you have greater than 50% inspiratory collapse, then the right atrial pressure is about 3 millimeters mercury. The gradient, using the modified Bernoulli equation, gradient is equal to 4v squared. The velocity we're talking about is the TR peak velocity. So you can calculate the right ventricular systolic pressure. Again, if there is no obstruction at the right ventricular flow tract, or there's no pulmonic stenosis, then the right ventricular systolic pressure is equal to the pulmonary artery systolic pressure. All right, so, and again, these are Doppler techniques. So you have to use multiple windows. And the reason for the multiple windows is that the angle that the ultrasound beam makes with the moving blood or the moving structure, that angle is very important. You want to get that angle close to zero as possible, okay? Because the smaller the angle, the greater the velocity, okay? Because we use the cosine of the angle. So it's a Doppler technique, so multiple acoustic windows should be examined to get the highest velocity. And this is just an example. This is a short axis at the level of the aorta. The cursor is across the tricuspid valve. This is your probe or transducer right there. Okay, when you have tricuspid regurgitation, blood is going to flow from the right ventricular outflow tract across the tricuspid valve and into the right atrium. So the blood is moving away from the transducer, hence it's going to be below the baseline. Okay, it's a systolic flow. Systole is from the onset of the QRS to the T wave. So you get periodic systolic flow, and these are the envelope. Peak velocity is right there. You put the curve, the sample volume, and the peak velocity is 2.89. So what the computer does, it squares the velocity multiplied by 4, and this is the gradient. So in order to get the right ventricular systolic pressure, all you have to do now is have the right atrial pressure. And we went over how to do that. We can also get the pulmonary artery diastolic pressure, where you need to have PI, pulmonic insufficiency, okay? So short axis at the level of the aorta again. The pulmonary trunk is right here. The pulmonary valve, the right ventricular flow, the right ventricular outflow tract is right here. When you get PI, pulmonic insufficiency, pulmonary regurgitation, blood is flowing from the pulmonary trunk across the pulmonic valve into the right ventricular flow tract. So therefore, the pressure in the pulmonary trunk have to exceed the pressure in the right ventricular flow tract in order for blood to flow in that direction. Okay, again, pressure gradient is equal to 4v squared, the modified Bernoulli equation. The velocity, so this is at end diastole, so we need to use the end diastolic velocity. Okay, so this is the velocity we're going to use. We're going to square it, we'll multiply it by 4, and that's the gradient here. Like the same way we rearrange the equation, okay, in order to get the pulmonary artery end diastolic pressure. All right, let me just develop that concept with you. All right, now let's go back. All right, so again, the gradient is the pulmonary artery end diastolic pressure minus your right ventricular end right ventricular end diastolic pressure. I think we developed the equation right here, right? So the gradient is equal to the difference in the pulmonary artery end diastolic pressure. And the reason why we have right atrial pressure is because your RV end diastolic pressure is the same thing as the right atrial pressure, same thing. So if you rearrange the equation, your pulmonary artery end diastolic pressure is equal to the gradient plus the right atrial pressure. Same right atrial pressure, we went over how to evaluate and get the right atrial pressure. Gradient again is equal to 4v squared. It's the end diastolic velocity, and we show you how to do that. Okay, so all right, so this is the velocity. So you can, in writing up a report, you can give not only the PA systolic pressure, you can also give the PA diastolic pressure. Now, we went on to discuss the mean pulmonary artery pressure because it's more accurate. If you want to make an assessment of pulmonary hypertension, it's more accurate to use the mean PA pressure, mean pulmonary arterial pressure. You can get the mean PA pressure by 1/3 of the systolic pressure plus 2/3 the diastolic pressure, and this will give you the mean PA pressure. You can also get the mean PA pressure by looking at the TR velocity and using that mean gradient. Okay, you can use the mean gradient, not the P gradient, but the mean gradient. You can also get the mean PA pressure by using the same 4V squared plus right atrial pressure, but you're going to use the early pulmonic velocity. So if you use the early pulmonic regurgitation velocity, you square it, multiply it by 4, and then you add the right atrial pressure to that, then you'll get the mean PA pressure. Okay, you get the mean PA pressure. All right, so and as mentioned, probably the best method or the simplest method is to use the mean PA pressure, the mean PA pressure. Sorry, the mean TR pressure, the mean TR pressure. That's probably the best method and simplest to use. But for those of you who are doing exams, you have to be familiar with all the methods because they can ask you, give you any of these concepts and ask you what's the main PA pressure. All right, so now we'll come to tricuspid, looking at tricuspid valve. And of course, the tricuspid valve separates the right atrium from the right ventricle. There are 3 leaflets. We have the anterior, the posterior, and the septal. You have to know how to identify them. Okay, usually the velocity across the tricuspid valve is less than the velocity across the mitral valve, and you get respiratory variation. One important thing to remember is that things that are occurring on the right side of the heart, you tend to get respiratory variation. So if they give you something looking like a TR or a MR Doppler envelope, the one that's look like it's varying respiration is going to be the TR, because what they will do is give you both, or they'll give you an envelope, systolic envelope, and show you it will be varying with respiratory. It varies. You get small ones, a little bit larger, small ones. When you have mitral regurgitation, you're not going to get that type of variation. So any stuff that occurs on the left side of the heart don't usually give you that type of variation. Okay, just like the mitral apparatus, the tricuspid complex, you have a caudinate, tendinate. There's supposed to be 3 papillary muscles, and you have the fibrous annulus. Okay, so stuff that can affect the tricuspid valve. You can get tricuspid stenosis, and rheumatic fever can also affect the tricuspid valve, and that can give you tricuspid stenosis. You can get tricuspid regurgitation. Carcinoid can also affect the tricuspid valve and can give you both stenosis and regurgitation. Tumors, vegetation, pacemaker lead. Again, sometimes when we put these pacemaker lead into the right heart, we don't give the lead enough play, and it presses down on the tricuspid valve, and you can get significant tricuspid regurgitation. You can get prostatic obstruction, aneurysm of the sinus of Valsalva. All right, so with tricuspid stenosis, not very common. It's not very common, but You know, if you see it, you should be able to recognize it. Because blood cannot get out of the right atrium, the right atrium will be dilated, and hence the neck veins will be engorged. So you get a fluttering discomfort in the neck because of that. The cardiac output is going to be reduced, and as a result, the patient will be fatigued, cold extremity. Because blood cannot get out of the right atrium, the blood will back up into the inferior vena cava, into the hepatic vein, so that the liver will be enlarged and engorged. So you'll get right upper quadrant abdominal discomfort because of enlargement of the liver capsule. You get jugular pulsation and the murmur that will go with it. So you know, clinically, if someone has tricuspid regurgitation, you can pick it up, but the echo, and if you are not seeing, I think it's a problem with your system, because I don't think anybody else have issues seeing. Okay, all right. So when we talk about tricuspid, so when we talk about tricuspid stenosis, again, you can get this with, a typical thing is carcinoid syndrome, and the valve will be fixed in place. So it will be thickened and it will be fixed in place. So you're going to get not only tricuspid stenosis, but you're going to get tricuspid regurgitation. So, and the Doppler will reflect that. Okay, so you'll get tricuspid regurgitation, which is a systolic flow. Okay, so you'll get a systolic flow, and then this is the diastolic flow across the tricuspid valve. You can get the gradient, you can do the gradient, and the gradient will reflect the degree of obstruction across a tricuspid valve. Okay, so carcinoid is one of the big things right there. Okay, so again, the TR Doppler signal and the tricuspid stenosis signal right there. All right, so if the patient has significant tricuspid stenosis, the mean gradient is usually greater than or equal to 5 millimeters mercury. When you look at the time velocity integrals, usually greater than 60 centimeters, and the pressure half time is greater than or equal to 190 milliseconds. They probably not going to ask you these numbers. You know, they will probably show you a picture of tricuspid stenosis and probably ask you the most common cause for it. You have to be able to recognize it though. Okay. All right. So the big thing though is tricuspid regurgitation. You have to know this inside out because it's very common. Okay. So about 70% of normal individuals will present with some degree of tricuspid regurgitation. And even though we say 70%, it's more than 70% because you can get, you're going to use your TR regurgitation, you're going to use the tricuspid regurgitation in order to get your RV systolic pressure. And you can get it in upwards of 80% of individuals. So some degree of TR is very, very common. Okay. But if you have significant amount of TR, you have to know the different, what's going to cause it. Rheumatic valvular disease not only affect the left side of the heart, it can affect the right side of the heart. Myxomatous change can affect the left and the right side of the heart. You're accustomed to seeing it more with the mitral valve, but it can affect the tricuspid valve. Epstein anomaly, not very common, but it appears on all tests. You have to know the definition of Epstein anomaly. You have to know how to recognize it, and they'll probably bring, show you an echo of Epstein anomaly. With Epstein anomaly, the tricuspid valve is very, very low in the ventricle, the right ventricle. So you'll have a huge atrium and a very small ventricle. The abnormality is mainly the septal leaflet of the tricuspid valve, which is displaced towards the RV apex. Okay, so you have a huge right atrium. And these patients tend to have significant amount of tricuspid regurgitation. And they also have arrhythmias, which is abnormal rhythm. Okay, but when we do congenitals, we'll go into this a little bit more. But you have to know, for exams, you have to know Epstein anomaly. Again, it's not very common, but it appears on all tests. Endocarditis, infected material on the tricuspid valve can give you tricuspid regurgitation. Tearing off the tricuspid leaflets, especially in blunt chest trauma, patient driving, unrestrained driver, and the steering wheel hit patient in the chest. I mean, all clinics have a patient like that. Every clinic have a patient who has had tricuspid valve rupture because of blunt chest trauma, and you have to repair it. Okay, you can get leaflet tear, you can get rupture of the papillary muscle and then prolapse of the valves. Carcinoid, again, not very common, but it appears in a lot of tests. And then pacemaker and defibrillator leads. When you put in these leads, you're supposed to have significant play. It's supposed to be fairly loose, not to constrict the leaflet, but sometimes that doesn't occur and the leaflet is restricted. So, all right. All right. So when we talk about tricuspid regurgitation, of course we get blood flowing from the RV across the tricuspid valve into the right atrium. So it could be a pure valvular problem in that the tricuspid leaflet may be not functioning for whatever reason, or if the patient have pulmonary hypertension, then there's increased back pressure, which cause the regurgitation. Okay, or so you have to think about it logically. So it could be a pure valvular problem, and the valve, for whatever reason, is leaking. If the annulus of the tricuspid valve apparatus is pulled apart, then the valve is not gonna co-opt properly, so you get leakage. Or it could be an increase in back pressure from pulmonary hypertension, and that's fairly common. Back pressure from pulmonary hypertension. The pressure goes all the way back, and the right ventricle is going to see increased pressure. the tricuspid valve going to see increased pressure, and because it's on the increased pressure, it's going to leak in systole. All right, so any cause of pulmonary hypertension will cause some amount of tricuspid regurgitation. Also, if you have any significant RV dysfunction, so if the RV is not contracting properly, then it tends to dilate, and the valve leaflets do not co-op properly. They do not close properly, and you can get tricuspid regurgitation from that. What are some of the signs and symptoms of tricuspid regurgitation? Now, if it's significant, then you're going to get decreased cardiac output. So patients will have fatigue, decreased exercise tolerance. If there is significant pressure now, remember, if there is significant pressure or significant volume going backwards, then the liver would see significant amount of blood flowing backwards. You get enlargement of the liver capsule because the hepatic vein will be engorged. So the patient will present with a congestive, what we call hepatopathy. So the liver will be enlarged and tender. Okay, you can feel it. They'll also get ascites. This is fluid in the abdominal cavity, peripheral edema, decreased appetite, especially if the liver is engorged, abdominal fullness from the ascites and the hepatomegaly, neck pulsation, because remember the blood is flowing backwards into the atrium. So the neck veins will be engorged and be distended. And the classic murmur for tricuspid regurgitation is the holosystolic murmur, which is going to increase with inspiration because it's a right-sided murmur. All right, so how do we determine the severity of tricuspid regurgitation? So the same way we look at the mitral valve and mitral regurgitation, you look at the valve structure, because if the valve structure is, if you see, say, a few cords are ruptured, papillary muscle rupture, you know you're going to get significant tricuspid regurgitation. You want to look at the leaflet mobility. Again, if the leaflets are fixed in position from, say, carcinoid, you know you're going to get significant regurgitation and stenosis. If the RV is dilated, you know the leaflets are not going to co-op properly, and you're going to get significant amounts of tricuspid regurgitation. Also, if there's a pacemaker lead in place and you can see it pushing on the valve, you already know that the patient is going to have significant tricuspid regurgitation. So, all right. So again, you have to know your RV inflow view. This is one of the better views to assess tricuspid regurgitation. Again, with your RV inflow view, the RV is on top. Okay, your tricuspid apparatus is right there. The posterior leaflet is right there. The anterior leaflet. Your eustachian valve is right there. This right atrium, and then just the coronary sinus is going to be right there, and your inferior vena cava is usually right there. All right. So a very important view, and that view will also give you probably one of your ISTR velocity as well. We went over assessing the size of the right atrium. So we have the major and the minor dimension. When you have significant tricuspid regurgitation, then a lot of blood is going to flow from the RV, cross the tricuspid valve, into the right atrium. So the right atrium is going to get large. And the RV also going to be enlarged because if you have significant amount of blood going back into the atrium, that same amount of blood is going to go forward. So not only the right atrium, but the right ventricle is going to be enlarged. So when we determine the severity of the TR, we look at the color flow Doppler, and we look at the characteristics of the TR jet. If it's a wall organ jet, or if you have the Cohander effect, then it usually suggests severity. So if the jet loops around the right atrial wall, it's usually a significant amount of TR. So the direction of the jet, the size of the jet, okay? And then the vena contracta is probably the most accurate tool you have to assess severity. And remember, the vena contracta is just the width of the regurgitant jet. And then PISA measurements, you have to know how to use the PISA method to assess severity, because that's what they're going to test you on. So, you know, if you look at your color flow and you get a jet which is very small, doesn't occupy more than 20%, and this is probably mild, you cannot use color flow only though, okay? You have to use all the tools. The vena contracta is probably one of the more accurate. So when you look at your TR Doppler, this is a C Doppler, then if it's just a faint jet, if it's rounded, if the contour is rounded, then it's probably just mild, okay? If it's triangular and dense, then it suggests severity, okay? So initially you can use your pulse wave just to identify the TR, but the pulse wave, you can look at your tricuspid inflow, and you can look at your hepatic vein flow. Hepatic vein flow is very important when you're assessing the severity of TR, because if you have severe TR, you're going to get systolic flow reversal. That's another thing they usually bring on all tests. So you cannot talk about severe TR unless you have systolic flow reversal. All right. This is your tricuspid inflow. Remember what we said, the velocity is usually less than that, what you see across the mitral valve. So, okay, so when you, again, you cannot mention significant TR unless you get a hepatic vein flow. So if you look at the top panel, this is the color flow is very minimal. The C Doppler is faint and it's rounded, okay? And then when you look at your hepatic vein flow, you get a systolic component, which is greater than the diastolic component. So this is mild TR, as opposed to severe TR. The color flow jet occupies a large portion of the right atrium. You get a dense triangular jet, okay? And then when you look at your hepatic vein flow, you get a systolic flow reversal, okay? So the systolic flow is on the opposite side. The diastolic flow is down there, and then you have atrial flow reversal, okay? So you have to demonstrate systolic flow reversal in order to call your TR severe. All right, so you need to go over TR, and that's one of the right-sided valvular pathology that you have to know real well, not only for your regular scanning, but also also for your exam, for your test. So it's one of those things you have to know inside out. So yeah, we're going to stop there. So so on Thursday, I think we will start